Hi everyone, it's such a pleasure to be here today. I'm so grateful for the opportunity to speak with you all about carer outcome measures. So let's get started. So I would like to also acknowledge the traditional lands that myself, Rachel, and Kira are all on today, the Gadigal people of the Eora Nation, and also pay our respects to Aboriginal and Torres Strait Islander elders, past, present, and emerging. So, in terms of what we're going to cover today, really what this session is all about is talking you through measures, so tools that measure carer outcomes or factors of being a carer in research and practice. So, to start off with, I want to kind of give you a bit of information on how to make the right selections for you, how to make the right selections of appropriate carer measures. I'm going to give you a bit of a tour of the many options of carer measures that are out there. And then myself and Kira and Rachel are going to talk you through kind of what goes into the development and validation of carer measures. So I thought that this kind of lends itself a bit to thinking about a buffet where really I want to, we all want to take you on a bit of a tour of a buffet where to start off with, I'm going to give you some tips and strategies and some things to think about, I guess, to refine your palate on making the right choices for you. Next, I'm going to give you a bit of a taster tour of the menu of choices of different outcome measures related to carers. And then myself and Kira and Rachel are going to give you a bit of a peek into the kitchen of how you actually make a measure, and the recipe and the steps. And even if you yourself are not going to ever make a measure, to ever want to develop a measure, we think that it's really good exercise to actually understand what goes into the construction and validation of a measure, because it can help you make the right choices of tools when you're using them in your research or evaluation or clinical practice. So I guess to start off with, this is really the who, what, where, and when of using standardized measures relevant to carers. And I'm going to give you, as I said, these key principles related to measures, and then go through a number of different domains looking at carer relevant measures. So, some of the key principles. I guess I first wanted to start off with really the when and why of when you would use a carer measure. And I guess for us, we're researchers and we're thinking a lot about carer measures in the research context. So we use measures a lot to first of all look at prevalence. So how big of an issue or how common of an issue is a certain thing within carer populations, or how big of an issue? What's the magnitude of that issue? Then we also want to use measures to understand change over time, to think about kind of the trajectory of an issue, using the same measure across time points. We also use measures to understand risk factors, so things to give us an understanding of, for example, are some carer groups more at risk of depression than others? We use measures to really better understand what are some of the modifiable factors that can influence outcomes for carers. And that can help us to kind of pinpoint interventions where we might be able to improve carer outcomes. And then also we use these measures to test if an intervention is working as a primary outcome measure or as a secondary outcome measure. And then also, of course, in clinical and service delivery, that measures can be used as well. So as a screening tool, as an assessment tool, and also to help in service evaluation and quality improvement. One of the things, I guess, that I wanted for people to maybe put in the chat, if you don't mind, is for you to just kind of give us a sense of how much you know or how much you use measures. Is this kind of your first foray into carer outcome measures? Are you kind of moderately across them, or are you kind of already an expert? I'll keep presenting, but I'll have a look at this as we go so that we can get a bit of a sense of how much people kind of know about carer measures. So the other thing that's really important to acknowledge is that carer measures can be tricky. It can be really hard to know which one to choose at what point. Psychological constructs, broadly speaking, are really difficult to measure, and that's because they're kind of not directly observable and they represent really complex patterns of behaviors and internal processes. And then I guess when we think about it in terms of carers, many concepts, there are often different definitions and ways of measuring them. And there's also a lot of, different overlapping concepts, and a lot of the measures actually look at the same issue from different angles or different lenses. So I guess that's all to say we need to be really thoughtful when we're thinking about what measures that we use for research, evaluation, and practice. So, what are some of the things that we look for when we're trying to select a good measure to use in a research project or an evaluation project? Well, firstly, we want to make sure that it's validated, wherever possible, making sure that it's a validated measure. And really, that's validity is that the tool effectively measures that the concept that we want it to measure, that it claims to measure. And there's lots of different types of validity that we're not going to go into today. But just to say, it's a really important concept to be measuring the correct concept. We also know that there's reliability. And that is to say that the tool is stable, where we're measuring it and then we measure it in a person the following week. We expect for it to be stable if nothing else has changed. And we want that kind of reproducing the same score each time it's administered if nothing else has changed. We also, though, want our measures to be able to detect change. That a tool is sensitive enough to change when it's administered at a later time and we expect there to have been change. We also want to look for tools that are interpretable, where we can understand the meaning of the results. It's all well and good to have these kind of numbers, but if we don't know what they mean or we don't know what the significance of those numbers means, then it can be really challenging. So having guidance, from the developers of the measure, to interpret what the scores mean. We want to think about tools that have a low burden, that are straightforward and easy to administer and easy to use and complete. And we also want to think about diversity. So making sure that we pick tools that can be used by individuals of varying literacy levels and cultural backgrounds and genders. So some of the questions, I guess, to ask yourself when you're going into kind of designing a study or thinking about how you might use measures in practice is what is the test being used for? Is it for clinical or research purposes? What are the outcomes of greatest significance or importance in your program or project? What's the retest reliability and validity of the different measures that you're weighing up against? What's the population that you're assessing? And I guess there's going to be a lot of different factors here, but some of the things that might be key are, was this measure developed in a carer population? Is this measure been developed for a specific population of carers caring for someone with a certain condition? Has it been developed for only partners of people rather than a variety of different carer relationships? So I guess think about, the population that you're assessing and also the population that measure has been developed for. What method of delivery is feasible? And are there any copyright issues and purchasing costs? And I guess all of this to say, it's oftentimes there's no perfect answer here, and it's, you never get all the stars to align to have a perfectly validated measure that's been developed in your exact carer population, that's, valid and reliable and all those things. But these are the things that you kind of want to keep in mind when you're choosing measures, so that you can try to optimize which one you select. So, in terms of the different carer measures that we're going to look at, I'm just having a scroll through the chat, and most people, it seems like they're moderately familiar, but really good to kind of get a sense of, the fact that people are moderately familiar. So hopefully we can tell you a few new things. All right. So firstly, we'll look at carer relevant measures of psychological distress. So this is, again, now we're at this taster tour of the kind of buffet of different measures. So I'm going to whip through these different measures. So in terms of psychological distress, it's often a really widely used concept and to measure, both in research and clinical practice. And that's because, these sorts of outcomes, distress, depression, anxiety, are really important. And they can be used for screening prior to more comprehensive clinical assessment, and can help us really find out if we need to be making some service allocations for carers. Strengths of these distress measures are that there's lots of them. They're well validated. Oftentimes they have good reference ranges and population norms, and they're often quite brief and easy to administer and available in lots of different languages. I guess collectively, the challenge here with these distress measures is they don't measure kind of a broader picture of a person's psychological well-being. So they're not measuring kind of protective or buffering factors. So things like well-being, coping, the benefits of caring. They're not diagnostic. These are measures that are often kind of screening or they're certainly not to be replaced. They're not to replace a psychological assessment with a trained person, but they can, give us an indication of scores that indicate clinically important distress. Also, none of these are carer specific, so these are broad distress measures, that are commonly used in carer research. So, bringing up a list of some of these common measures, you might have seen these before, some of them, and you might have used them before. And you might have kind of your favorites or ones that you go to. So I guess to start off with is the single item measure, the distress thermometer. Um, if you put in the chat of which ones that you've seen before or you know of or you use, that's great. So in terms of the distress thermometer, it's a single item measure. With it's freely available, has many translations. It's been tested a lot among carer populations, and the cutoff score of about 4 or 5 has been determined to really highlight meaningful, clinically meaningful distress that warrants further investigation. There's also an associated problem list. The problem list was developed for people living with a health condition primarily. I have seen some carer adapted problem lists, but they're kind of still in their infancy. Then I've got kind of what I've grouped together as the broad measures of distress. So you've probably heard of the K10, there's the HADS, and there's the DAS. So these are all kind of broad measures in that they're covering multiple specific concepts of distress in the one measure. Now, some of the kind of pros and cons of these, the K10, which is obviously really brief, doesn't tend to provide that really good breakdown of distress type. Whereas the DAS, for example, it's longer, it's 21 items, but it does include kind of subscales for depression, anxiety, and stress. The HADS is also commonly used, and it's kind of a nice middle ground here. I guess one thing it does do is it excludes the physical symptoms of depression and anxiety. So it's often good for people living with a health condition because, for example, in our cancer populations, there might be physical symptoms that are a result of a treatment rather than necessarily the result of the condition of the kind of anxiety or depression. So I guess here's these broad measures of distress. Then we go to specific measures of anxiety or depression. So a couple of quite specific anxiety measures are the GAD-7 and the Beck Anxiety Inventory. I guess some key differences or considerations to think about here is the GAD-7 is obviously a lot shorter. It's 7 items and focuses predominantly on those cognitive symptoms of anxiety, whereas the Beck Anxiety Inventory includes a lot more of those physical symptoms of anxiety as well. Then we've got 3 measures of depression. We've got the PHQ-9, the CESD, and the Beck Depression Inventory. So again, there's lots of similarities and differences between these. Of course, PHQ-9 is shorter. PHQ-9 and the Beck Depression Inventory also have a suicidality screening item. So that could be important for a specific types of studies or specific types of populations. So that might be a consideration that you want to take into account. I guess the benefit of the CESD is it looks at positive and negative affect. It looks at kind of a broader definition of depression in terms of the things that might be buffering against it. So that's our specific measures of depression and anxiety. I guess also to say that there are other specific measures of distress that sit outside of, or I guess alongside depression and anxiety. So one of those is stress. So the perceived stress scale is a widely used measure of stress. There's also, I guess, this transdiagnostic construct of death anxiety, which is used in a number of different kind of contexts, but can be important for some carer populations as a bit of a driver of psychological distress more broadly. So we can see that there are a couple of nicely validated measures here: the Collett-Lester fear of death scale, and the death anxiety beliefs and behaviours scale. And as well, we can also have measures of other specific types of distress that can be quite related to a condition. So Kira will speak to you a little bit later about fear of illness, recurrence, or progression, and that we've got some measures there looking at that specific element of distress. So I guess now thinking about carer burden or carer strain, and I want to make a really clear note about, the concept of carer burden and the language and the terminology that we're using here. And I think it can be quite problematic, and oftentimes there's quite a solely negative focus. The term carer burden can also really reinforce stigma of carers or of people with illness, and can kind of engender feelings of guilt or shame. And it certainly it doesn't capture the full picture of the positive and challenging aspects of care. Um, some people prefer to kind of replace the term carer burden with carer stress or carer strain. I guess today I wanted to give you carer burden measures because it's certainly a concept that is widely measured, and can have its place in research, and clinical practice in terms of understanding the challenges that carers are experiencing. Um, so, in terms of the measures that are commonly used, many of you have probably heard of the Zarat burden interview. There's multiple versions of this, with multiple different kind of iterations of items. It's been kind of widely used and validated in many different settings. There's the modified carer strain index as well as the carer burden scale. So all of these really do have that quite negative lens, reporting on kind of the very challenging aspects of caregiving. Guess one of the differences with a different measure is the Carer Reaction Assessment Scale by Barbara Given and colleagues, and it's an oldie but a goodie, and it measures both the positive and negative reactions to caregiving. So I guess that's a point of difference and one that you might be interested in having a look at further. So now to carer quality of life measures, and again I've kind of split these up for some of the different elements of quality of life that we might be looking at. So first of all, I've given you a couple of comprehensive measures, and I really like this measure, which is the adult carer quality of life. It's 40 items, so it's a long one, but it has a lot of different domains that it looks at, and it assesses the levels of support a carer is getting, caring choice and stress, money matters, personal growth, self-value, and satisfaction, as well as their feelings of ability to care. As well as another kind of comprehensive, quite different measure of carer quality of life is the FACT-G caregiver, which is 27 items, and it is an adaptation of a person living with illness measure, but that's been adapted to carers. And it measures things like physical well-being, social and family well-being, emotional and functional. So you can see here, this is the adult carer quality of life measure, which has, a number of different domains. And these are domains that are sometimes less captured in a lot of the carer research, as well as that FACT-G, which has got items across those different domains. Then we've got carer quality of life, and I kind of group these together as brief measures of carer quality of life. You've probably heard of a number of these. So there's the carer qual, the Ascot carer, and the carer experience scale, all measuring somewhat similar concepts of quality of life, but much briefer than those other kind of more comprehensive measures. So again, it depends on what you're doing, the purposes of your study, or program that you're using. But these are all kind of quite well validated carer quality of life measures. Now to unmet needs, and this is a really interesting concept. And while I've been constructing this presentation, I've kind of made a few discoveries around carer unmet needs. So what are unmet needs? They're the practical, social, relational, emotional, informational, and communication needs of a person, and particularly looking at whether those needs are being met or not. And it's really important for kind of service planning and service provision. Some of the limitations, I guess, and this is what's been really interesting, is I think, myself and Rachel and Kira work in psycho-oncology, so we're working predominantly in cancer, and this is a really kind of utilized measure in the cancer setting. But as I've been kind of looking, it doesn't seem to be that there's as many available measures of this concept outside of cancer. Um, so I think, that's a real challenge here. I guess the other thing is it is less developed and validated in the carer research more broadly. It's often used with people living with an illness rather than in carers. As well, the measurement of this concept is complex because it's not like a light switch of I'm getting my needs met or I'm not getting them met. It's more complex than that. Like sometimes people's needs can be partially met or they can be met, but it's been really difficult and you've had to fight, with on the phone for 12 hours to get your needs met. Or sometimes they can be met and other times not. So I guess this is complex to measure, but still an important concept. So I had a look at some of the different systematic reviews of unmet needs measures, and what I found was what I suspected, which is a lot of them are cancer specific. So 13 out of 17 in a very recent systematic review were cancer specific unmet needs measures for carers. The one that is most commonly used in our work is the supportive care needs survey for partners and caregivers. Um, it's 45 items and it looks at a number of different domains: health service needs, psychological, emotional work, information needs, and social needs. And it was adapted for the general population in 2020, but still probably needs a bit of work in terms of adapting it further and validating it further. There's also the carer support needs assessment tool, but the focus of this one is kind of much more on that end of life palliative phase of caregiving. There's also the carer needs assessment for dementia, which is a structured interview and perhaps not as applicable for like a research study where someone would be filling out a measure. And then I saw recently there's been an unmet supportive care needs survey for families of children with chronic health conditions, recently published and developed. So I guess this is a bit of a watch this space for carer unmet needs. I do know, there's also the carer's star. And actually, I was in a meeting with people, that working in Carers New South Wales, and I know that someone mentioned the carer's star, and I thought, oh, never really known about that. So I went digging. And so I'm sure many of you perhaps know and use this. So it covers health, the caring role, managing at home, time for yourself and how you feel, finances and work. And it can be a really beneficial way for service providers to identify areas of concern and need. And from what I can gather, and you all in the audience here probably know a lot more about it than I do, it's widely used in the UK and used by Carer Gateway. I couldn't find a huge amount of academic literature on it in terms of validation studies or studies using it. I did find a great impact evaluation of Carer Gateway, and some interviews done with people utilising this measure. And there was a bit of kind of discussion about, the positives and the challenges of utilizing this. And one really nice quote was, I think in some ways the conversation is good, but as a measurement for outcomes, it perhaps isn't the tool for that. So I guess that's one thing that is an interesting and perhaps is born out of maybe the lack of availability of other unmet needs measures more broadly. I'd be interested in people's thoughts on that if there's some time to discuss it. Also, I guess this is a bit of a catch-all of other carer relevant measures that you might not have heard of or that you might be interested in including. So first is carer preparedness. There's the degree to which a carer feels prepared to manage the caring situation. So there's the preparedness for caregiving scale, which is quite a brief one, 8 items. There's also a similar concept of carer motivation. So the motivations for caregiving, whether a person is kind of doing being a carer, the reasons that they've taken on the caring role, are they kind of intrinsic or extrinsic? And this can be really important to understand, the caregiving situation and perhaps kind of the outcomes that carers might be experiencing. There's also carer health literacy, which is there's one that was developed, the health literacy of caregivers scale for cancer by a colleague of ours, Eva UN in Melbourne, which has got 46 items across 10 domains. But then I also found that there was a study recently done looking at health literacy of carers of older people with a chronic illness. And both measures cover, a carer's ability to seek, understand, and evaluate information, communication with the care recipient, healthcare professional and support networks, and carer engagement and ability to navigate healthcare systems. So some really nice measures there of different elements of carer health literacy that are worth kind of looking into. We also know that carers' sense of confidence and mastery can be really important kind of mediator of outcomes. So there's these measures here of self-efficacy, the revised scale for caregiving self-efficacy, and the carer self-efficacy in contributing to a patient self-care scale, as well as a related concept of mastery, which is really looking at a carer's confidence and perceptions, self-perceptions of competence in their caregiving role. And then, of course, there's the benefits of caring, which are oftentimes not measured in many studies, and I think are really important for us to talk about and consider when we're looking at carer outcome measures. So one of them is the positive aspects of caregiving scale and the benefits of being a caregiver scale. Both of them capture some of those really beneficial aspects of caring, things like purpose and fulfillment, personal growth and development, strengthened relationships, increased self-esteem and self-efficacy. So that's it in terms of your refining of the palate and taster tour of the menu. I guess for the rest of this talk today and the presentations are really going to be about now a peek inside the kitchen of how we go about constructing a measure from kind of those early developmental phases all the way through to how we might use them in clinical practice. So I'll stop the share there, and I guess Prue, over to you while I bring up the next presentation.
Thank you, Rebecca. I just wanted to say first and foremost that I really, as a carer myself, value hearing that these psychological distress elements are being really considered. Not just in relation to the experience of caring, but also in relation to the experience of participating in research. And I guess that just kind of brings me to one quick question. I know we are short on time. Um, uh, of From my own experience in, being a carer and participating in research, and then also now not actively caring, there's more reflection post caring of what that distress is, what the burden actually was. Once you're out of the kind of mud of it, you really understand it. So when kind of, taking in these insights and considering this research, how are you ensuring that you're getting that full picture when sometimes carers are kind of blocking out perhaps the true distress of the situation because really recognizing it in the moment might make it impossible to continue.
Mm. It's such an important point, and I think that it's one of the challenges that we experience when we're looking at this in research and in clinical practice. I think having carers involved from the outset of our research projects, and I think having carers who are, I guess, in the thick of it, in the thick of caring, as well as carers who are bereaved, or in the cancer setting, I guess, having carers who. So we've got a number of kind of carer consumers who are bereaved, but then also some who have their loved one has gone on to kind of finish their treatment and continue into survivorship. And I guess having the variety of caregiving perspectives when we're developing a study and when we're kind of refining which measures we might select can really be helpful because people can go, oh, actually, I was thinking more about these things when I was going through, the thick of caring, or having I guess those different perspectives can be really beneficial to help us in constructing the right choosing the right measures at the right time. And then I also just as a qualitative researcher to say I also think there's really a place for qualitative research in a lot of this. So having that measures are really important, and there's lots of places for quantitative measures. But I'm a staunch qual researcher as well, and I think that sometimes we can't capture everything with measures, and we need to use interviews to be able to fully capture the whole experience, and that can point us to what we might not be actually capturing in some of these measures.
Mhm. And just one more question that's come through from the chat from Louise. Louisa said that they are interested if there is a measure for parents and carers of young people with mental health difficulties.
Hmm. So there was that unmet needs measure of parents and carers of young people. It was with a chronic health condition, I think, rather than specifically looking at mental health. But it might be an interesting one to have a look at to see, if it might be one of those situations of here's an adjacent measure. We don't have it validated in the specific population, but perhaps it might be an appropriate one to utilize or pilot in a specific population. I guess also to say there was a lot of information in those slides, and I'm really happy to share them if anyone would like, because I guess there's lots of details in there and studies you might want to go and have a look at. So I'm really happy to share the slides if anyone is keen.
Wonderful, thank you. All right, I'll hand back over to you, Rebecca,
Okay, great.
to
Sorry,
now.
you get me twice and then you get a break from me. Um,
You're going to talk us through some initial work from your lab
yeah,
in
yeah.
developing new care measures, which is exciting.
Yeah, great. Thank you. So this is the development of the caves scale, which is very early in its development. And if anyone saw presentation yesterday from my PhD student Hannah, this is kind of work that's flowed on from Hannah's PhD. So I guess to acknowledge this is a team effort. I have a wonderful honours student this year, Charlotte, and a great team of researchers in our lab working on this at the moment. So I guess what we know this, very much is that carers tend to experience high levels of strain, high levels of psychological distress across anxiety and depression. But we know that there's quite a treatment and engagement gap. And if anyone saw Hannah's presentation yesterday, you would have seen that she's working on how do we bridge that gap. We know that there are many carers who need psychological support and desire it, but that there's something that's stopping people from actually accessing it. And to bridge that gap, we need to understand why it's there and what we can change. So I guess there are lots of things that feed into this, right? There's the fact that perhaps there's we need effective and available support and treatments to be able to bridge that gap. We need to have an understanding of attitudes and barriers to uptake of psychological support. We need, interventions that might enhance the uptake of psychological support. There also, this exists in a broader kind of health service and policy context, and there's probably some changes that need to be made there, as well as kind of social and cultural changes that need to be made to kind of bridge that gap. Um, and so, as I said, Hannah presented yesterday on, why do some carers not engage with support? And Hannah's done a really great qualitative review of this concept. And what she's found is that some carers really struggle to identify with the caregiving role. And we know that we heard that from a lot of different presentations yesterday. That, some people might not recognize that they are carers, or not recognize the impact of caring, might be dismissing their own needs, or might feel guilty for acknowledging that they're a carer. Some carers, may view support seeking as not useful. There's quite a bit of mental health stigma around that can exist, and Hannah's qualitative review found that. as well as some carers might struggle to see their own needs as valid and worthy of psychological support. Um, so I guess there are lots of these kind of attitudinal barriers to that might stop someone from seeking psychological support. Um, and as much as I love qualitative research, we also, sometimes we need a quantitative measure. And there's a real lack of quantitative measures, really looking at how big of a problem this is and how common these attitudes are. And so we kind of as a group discovered that we need a quantitative measure that looks at the carers' attitudes towards their role, how they value their own needs, and what their attitudes are towards seeking support. There are a few relevant measures, but none of them really quite did, hit the nail on the head for us. So, there's, some here are kind of relevant or adjacent to the concept, but not really looking at what we need to, what we want to be looking at. So that's where we've come to develop the CAVE scale, which is the carer attitudes towards their value, towards their self-value and engagement with support scale. And the aim of this study that I'm talking to you now is to develop a measure that captures the attitudes of carers towards their role and value, their engagement with support, and any of those attitudinal barriers. So what we're doing is we're developing this scale kind of from the ground up. So this is really right at the start of the process. And what we're doing is we've taken the qualitative review from Hannah and also looked at other published literature and other published scales. And we've developed a draft scale based on all of the literature. Currently, it has 6 different domains and 43 items on a 5-point Likert scale. And now we're actually going to take it to people who work with carers, so researchers and health professionals, as well as to carers themselves, to get their feedback on these items. Really to say, do these items resonate with you? Do you understand the wording of them? Are they tapping into concepts that are significant to you? And then we're going to use that feedback to iteratively revise the scale. So this is all qualitative work that will feed into a measure. We're going to interview those professional stakeholders, as I said, as well as carers of people with a chronic illness to get their perspectives on all of the different items that will feed into eventually a measure. So here's just a bit of a taster of what the CAVES scale currently is, but as I said, it's going to iteratively change over time. So the first domain really looks at carers' identity and role perceptions. So items include things like I identify as a carer. Caring for my loved one is an important part of who I am. So looking at getting people's responses, their sense of agreement or disagreement with that. The second domain is around role concealment, and I really haven't found many studies and many measures that actually look at this. Around to what extent does a carer conceal their role or conceal the strain of being a carer? So, an example item that we've got at the moment is I try to hide a lot of what I do for my loved one as their carer to protect their dignity. Or admitting that caring is hard would be offensive to the person I care for. So looking at what are people's agreement or disagreement with those concepts. Validation of carers' own needs. So looking at to what extent does the carer view their own needs as valid and worthy. Looking at how carers value their own needs relative to others. So something that came up time and time again in Hannah's review was, as a carer, my loved one's needs should come above my own, and really understanding, those sorts of features of what might feed into being attitudinal barriers to carers receiving support. Recognition of carer value from others. So, understanding and measuring the extent that the carer feels recognised and valued. And then finally, empowerment to seek support. So, developing items that really look at the extent to the carer feeling aware, confident, or empowered to access psychological support. So that's kind of in its very draft stage. So this is, right at the beginning. So we're going to start recruiting people over the next week or two to have a look at the measure and give us their kind of honest perspectives on, what else do we need to be looking at? What should we ditch? What should we change the wording of? I'm sure people have already got thoughts and ideas, which I'm super open to. So I guess where to next with this one? So we're doing a qualitative Think Aloud study this year as a part of Charlotte's honours program. and we're going to refine the instructions, the response options, the domains, and the items. And then next year, we're going to take it out to a broader, the kind of refined measure out to a broader range of carers to test, to look at validating it. So yeah, if anyone's interested in looking at the scale or talking more about it, I'm super keen to talk with people. So I guess that's it from me there, and hopefully the next presentation will give you a bit more info on what it looks like once you actually get to having a more refined scale and what the next steps are. So thanks so much.
Thank you, Rebecca. I am really excited to see where this goes. I think while listening to you speak about all these different elements, I really could acknowledge my own experience as a carer, particularly that first phase of not necessarily recognizing that you are a carer and what those different blocks are. And then also that element of, what blocks people from seeking their own support. I know it took me quite a while to seek any kind of support within my caring role. And I think being involved in the care and knowledge exchange and hearing other experiences really helped me with my own identity as a carer and with my own needs. From that perspective. One quick question for you before we step on to the next element. Um, Once this is all done, how would you expect researchers or policy makers to be able to use this measure?
Hmm. Um, so I think there's a number of different ways that it could be used. Um, I guess to start off with, it's to see what's the magnitude of the issues. And that's really as the foundational piece of us knowing that there's this gap, right, between carers needing psychological or demonstrating that they're in need of psychological support and having high levels of distress, and the service uptake being quite low. I guess understanding the magnitude. So which of these issues might be driving that gap? So I guess that's one of them is kind of prevalent stuff. Also to look at, I guess, what's a mediator or a moderator. So what elements of this might be, mediating whether a certain people would actually take up or not take up, or certain outcomes, whether a certain carer's attitudes can feed into what sort of outcomes they have. And then finally, I guess where this came from is that Hannah is developing, as people would have seen yesterday, Hannah's developing an intervention to look at how we can connect carers with the right support for them. And all of this came out of the fact that we were looking for an outcome measure to see, are we changing attitudes? Is our intervention, which is addressing many of these attitudinal barriers, is it actually going to, is it going to change any of their attitudes? So to look at kind of pre and post, are we able to change attitudes? And and does that have a flow on effect? So I guess there's some of the uses, but I'm sure there's lots more that I'm just not thinking of at the moment. I think Prue may have disappeared, which is I'm hoping she comes back. But I guess why don't I introduce Kira? Kira is our next speaker. And Kira is going to be talking to us about the validation of the development and validation of another carer specific measure. And Kira, I might hand over to you.
Cool, thank you. Can everyone see my slides okay? Excellent. All right. Today, I'll be talking a little bit about, from a different perspective, in why it's important that we adapt and validate measures for the population that they're intended for. So I'll be talking a little bit about some work that we conducted as part of my PhD to develop a carer measure of fear of cancer occurrence and progression, which we called the CARE FCR. So just to give a little background about fear of cancer occurrence, this has been a really well-defined construct in people living with and beyond cancer. So we define this as the fear, worry, or concern relating to the possibility that cancer will come back or progress. And as there's been a lot of research done in people living with cancer, we know that fear of recurrence is characterized by intrusive thoughts, about the cancer coming back or progressing, maladaptive coping strategies such as requesting additional scans, or conversely avoiding medical appointments altogether, impairment in function, high distress levels, and difficulty planning for the future. And I just wanted to give a little overview of the survivor fear of recurrence literature, which has largely informed what we know about carer fear of recurrence to date. So just to give you a little bit of context about how much has been done in people living with and beyond a cancer diagnosis, we have a lot of measures which have been validated and tested for validity and reliability in people living with cancer. In two of the kind of core reviews that were conducted, there were more than 130 papers, and that was over 10 years ago. So a lot of literature in this space. And as a result, we have clinical cutoffs to identify those that are experiencing really high levels of distress and worry. And we also have clinical guidelines which have been established to guide screening, referral to different treatment pathways, and have really guided research efforts in this space. And finally, as a result of the identified need and research in this area, we have multiple interventions which have been developed to address survivor fear of recurrence, and we have strong evidence to support the efficacy of these interventions. And now switching to looking at carer fear of recurrence. So we know that carers experience fears and worries about their loved one's cancer coming back or progressing. And when I started my PhD, kind of a first step for us was understanding, okay, well, what levels of fear of recurrence do carers experience, and how are we measuring this? And so we conducted a review specifically looking at the measures that are being used, and we found that 12 multi-item measures had been used in previous studies. And what we found was that these were mostly survivor measures used with adaptation for carers, so changing the wording to use there before cancer and removing irrelevant items. And what we did was we wanted to look at how well developed and validated these measures were. And what we did was we used a criteria called the Consensus-Based Standards for the Selection of Health Measurement Instruments, or the COSMIN. And this essentially looks across a number of domains with reliability and validity, and checks whether those tests have been done in developing the measure. And so I don't expect you to be able to read through this big graph, but what I hope you can get a sense of is how much red is here, which is indicative of criteria not being met. So we have the criteria here on the vertical axis and the measures here on the horizontal axis. So a lot of the tests that we need to have validity and reliability of measures were not being done when these carer measures were developed. And okay, aside from psychometrics, you may be thinking, okay, well, why do we need a carer specific measure? And when we look at the qualitative literature that has been conducted, we find a lot of similarities between survivor and carer experiences, specifically around fear and uncertainty, but we also find a lot of things which are unique to the carer experience. And these include caregiver's role as protector, fear of losing a loved one, and a sense of personal responsibility around identifying signs which may be indicative of the cancer coming back or progressing kind of thing. And so it's these carer-specific aspects of fear of recurrence which are not being captured by current measures, which may have implications for the estimates that we have. And so we conducted a study with the aim of developing a carer-specific measure of fear of recurrence, and we divided this into two phases. So the first phase involved generating items, and we developed these items using qualitative systematic review data, as well as quotations from a series of interviews with cancer carers. And so we had items including fear of cancer recurrence, fear of cancer progression, communication about fear of recurrence, as well as looking at coping strategies. And then in the second phase, we validated this measure. So we recruited cancer carers to complete an online survey that included our intended items, the care FCR, as well as demographic questions and related measures that would allow us to run data analyses to assess assess the structural validity, internal consistency, and test retest reliability. And so I won't go into great depth about the different psychometric testing. This work has actually been published if you're interested in reading a little more about it, but I'll briefly go through these. So we had an initial measure including 49 items. We had 438 carers complete the surveys. And we conducted a factor analysis, which basically whittles down the number of items that are relevant and takes out those that are kind of assessing the same things and divides them into groups them into like relevant dimensions. So we had 3 dimensions. Ours were fear of recurrence, fear of progression, and communication. And then when we looked at the reliability, we had good values for internal consistency and good test retest reliability. So with when carers completed the measure 2 weeks later, it was stable over time. And when we looked at validity, we found some strong positive correlations between our measure, the CARE FCR, and other fear of recurrence measures. So this indicates to us it is measuring what we're intending. And we found kind of moderate correlations between the CARE FCR and related measures. So in our case, this was depression, anxiety, death anxiety, and metacognitions. And we chose these measures because there's been previous associations found between fear of cancer recurrence and these constructs. Oh, and so just before I wrap up, I just wanted to talk about our measure at an item level and just really highlight where there are some similarities and differences. So in terms of similarities, in the context of fear of recurrence, we had an item here, how often do you think about the cancer occurring, which is really tapping into the frequency of worries and fears and is something that we would expect to see in a measure for people living with cancer. Additionally, we have I feel overwhelmed by my fear of the cancer occurring. So the outcome of experiencing those fears. And again, I'm afraid that if the cancer progresses, it will be incurable, which is kind of an outcome related question. And these are some items that you would expect to find something similar on for a measure for people living with cancer. And finally, we have some differences. So this question here, I worry that if I'm not looking for changes, we may miss early signs of the cancer progressing. It's quite carer specific. This is kind of a communication item. I worry that talking about my fears related to the cancer will upset the person I care for. And finally, when I am with the person I care for and information about cancer appears, I try to distract them or change the topic. And this is a behavioral question and really taps into the carer experience. And it's these different items that are not currently, not previously, included in carer measures of fear of recurrence. So some key takeaways, it's really important that measures are relevant and valid for the intended population. In our case, we had a 3rd dimension communication, which isn't currently included in cancer survivor measures. And so that's an area that was not previously being captured. We developed the CARE FCR, a final measure including 23 items with 3 dimensions, fear of recurrence, fear of progression, and communication. And just to, identify some future directions that we could look at with our measure, a valuable next step would be further testing to establish a clinical cutoff to help identify those with the highest levels of fear and worry and understand what that looks like for carers, and the creation of a short form to make this measure more accessible. I'm not sure if we've got time for questions or not, but I'll stop sharing screen. And I just wanted to thank the carers that have been involved in this research, the research team, and the funding that I received to support me in my PhD.
Thank you, Kira. Sorry, I dropped out there for a minute. I had some technical issues. But yes, we are running a little low on time, so we'll skip questions for now on this one and jump into our next presentation, development of the Supportive Care Needs Survey Partners and Carers Screening Tool. So I'd like to welcome Dr. Rachel Campbell now, who will present on how her and her team took a longer measure of unmet supportive care needs and adapted it to become a shorter screening tool.
Thank you very much. Can I just check, can everyone see my slides?
Yes.
Perfect. Okay, thank you. Yeah, hi everybody. So I'm really happy to kind of be part of this session this morning. And as Prue said, I'm going to be talking about work that we did to develop a screening measure to detect unmet supportive care needs in carers of people with a brain tumor. And so, although this presentation is quite specific to carers of people with a brain tumor, I kind of hope that this will be interesting and relevant to at least some of you in terms of thinking about, perhaps you might have an interest in adapting longer measures that are available for use as screening tools in clinical practice to kind of assess needs of carers. So hopefully the sort of method that we went through may be of interest to you or even the measure itself. So before I kind of get into exactly what we did, I just kind of wanted to start off by talking about the kind of key differences between using measures for screening purposes versus using them for assessment purposes. So the purpose of using measures for screening is really to try to identify carers who are at risk or who are in need of further assessment. Whereas the purpose of assessment measures is really to provide a more in-depth kind of comprehensive coverage and assessment of whatever your particular outcome of interest is. And so screening measures tend to be much briefer and less resource intensive, whereas assessment measures tend to be longer and typically require more time and resources for them to be administered. And so often within clinical practice settings, the screening measures often precede those longer, more comprehensive assessments. And so the sort of key considerations to keep in mind when choosing a screening measure for use in clinical practice settings is really to select a screening measure that is feasible for routine administration in clinical practice. And so when we say feasible, we mean it needs to be, I think, sufficiently brief that carers are happy to complete it. It also ideally would require kind of no specialist training on behalf of the person administering it in order to administer it, and sort of tied to it being brief, we don't want it to be overly burdensome for carers to complete. And then the other kind of key consideration is ensuring that whatever the screening tool that you select for use in clinical practice, you want to make sure that there is evidence available that actually demonstrates that your screening tool is kind of actually capable of accurately identifying those carers who are at risk or who are in need of further assessment for, again, for whatever the particular outcome is that you're interested in. And so I want to just give you an example of the work that we recently did where, as I explained earlier, what we did is we adapted a longer assessment tool that was designed to assess the unmet supportive care needs of cancer carers. And we transformed that tool into a briefer screening tool for carers of people with a brain tumor. So I just want to provide a little bit of background before I kind of go into telling you exactly what we did. But much like carers of people with other chronic illness, carers of people with a brain tumor experience reduced quality of life, increased levels of distress, and very high unmet supportive care needs. And we know from previous research that these high unmet needs remain constant over time, but the kind of type of needs that the carers have do evolve and change considerably over time. And so this sort of speaks to the need for routine assessments of these needs because they remain high, but also the types of needs that carers have do change. But despite all of this, there's no kind of standardized approach within clinical practice settings to identify and address the supportive care needs of carers of people with a brain tumor in clinical practice settings. And so to try to address this issue, we conducted work to develop a measure to screen for the unmet needs of carers of people with a brain tumor, which we hoped could then be used to guide referrals to appropriate supports within clinical practice settings. And so to do this, we used the Supportive Care Needs Survey for partners and caregivers, which is one of the most widely used measures that's designed to assess the supportive care needs of cancer carers throughout the patient's illness trajectory. and it includes 44 items that assess unmet needs across these 4 different domains that you can see on the slide here. And so we aim to adapt this measure to create a briefer screening tool specific to carers of people with a brain tumor. And so how did we do this? Well, we were quite fortunate that we were able to access data from a randomized controlled trial of carers of people with a brain tumor, where all of the carers had completed that longer 44-item supportive care needs survey at baseline. And so we had access to that data, and then we were able to perform secondary psychometric analysis on that data to develop our briefer screening tool for people with brain tumor. And so some of you may perhaps be unfamiliar with psychometric analysis. And so what it is that it's a type of statistical analysis that we use to develop questionnaires. And we use it to ensure that questionnaires are reliable, valid, and appropriate for their intended use. So all the things that Beck talked about in her presentation at the beginning. And we use psychometric analysis to make sure that we're really using the right questions to measure whatever it is that we want to measure. And in the context of this study that we conducted to develop the screening tool, we use psychometric analyses to make sure that we were including the right number of questions in the screening tool that could adequately detect the unmet supportive care needs of carers of people with a brain tumor. And so essentially what we did is we performed a whole series of psychometric analyses on this data to try to develop our screening tool. And so by performing these psychometric analyses, the kind of overall goal was that we were trying to identify a subset of items that were the most informative, the best performing items that were the best at detecting the largest group of carers of people with a brain tumor that had unmet supportive care needs, so that they could then be triaged for more comprehensive assessment with follow-up measures. And so Kira sort of talked through a few of these analyses in her presentation. I'm not going to go into it in too much detail, but I'll just sort of briefly talk about the steps that we took. So we performed exploratory factor analysis, whereas we looked at how the different items or questions within the measure fell into different supportive care need domains. And we considered in our analyses that questions or items that had larger factor loadings were sort of the better performing items, the more informative ones, and better candidates for inclusion in our screening measure. And in addition, we performed frequency analyses. So this means we looked at the percentage of carers in the data set who were indicating that each question or item was an unmet need for them. And so we considered items that had the largest number of carers who were endorsing those items as unmet needs as better candidates for inclusion within our screening measure. We also conducted analyses which are called simple linear regressions, where we looked at how well each individual item predicted scores within a particular supportive care needs domain. And so those items that were better predictors on their own were then considered better candidates for inclusion in our screening tool. And then finally, we did something called receiver operating curve analysis, whereas we looked at each individual item and also groups of items together. And we looked at how well these individual items or groups of items were actually able to distinguish between carers who had some level of unmet need versus those who had no unmet needs. So either their needs were already satisfied or they reported they had no needs. And so basically we went through kind of a step-by-step process where we conducted each of these analyses. We started by looking at these individual items, and we conducted these analyses. And then we looked at different combinations of 2 and 3 item combinations, and again performed additional analyses. And from that, we were able to identify a subset of items that were the best performing, most informative items that we would then include in our final screening measure. And so this is kind of the ultimate result of what we did. So these are the 6 items that we ultimately ended up including in our screening tool. And as you can see, it contains three items that focus on unmet supportive care needs in terms of the impact of caring for someone with cancer on the carer. And it also includes three items which assess unmet information and communication needs. And so obviously, this measure, we developed it specifically with carers of people with brain tumor in mind, but we do think that it has kind of broader applicability and could be used more broadly across cancer populations. And I think there is potentially also the scope to be, looking at these sorts of measures for unmet needs and possibly adapting them and or seeing how they could be adapted to be appropriate for carers of people with other types of chronic illness. And so I just have included here a QR code with a link to that paper, which goes through the step-by-step process and explains it of what we went through to complete that, develop that screening measure. And so if anyone's interested in that, then please do take a look at the paper. And if you are interested in, developing screening tools or learning more about our work, then also please do feel free to contact me. Thank you.
Thank you so much, Rachel. I think that work that you're doing, looking into the unmet needs of carers, is something that is very, very valuable. So I am very much looking forward to seeing where that goes. All right, we are going to move on as we are short on time today. So welcoming back Dr. Rebecca Lassiter-Powell, who will now detail how she's using screening and assessment measures in a clinical pathway to connect carers with the right supports.
Thank you so much, Prue. I guess this is hopefully just going to be a quick presentation, kind of going full loop on how we might use some of these measures to then, work into clinical practice. So I want to acknowledge that this is not just my work, and there's a whole team of people who have been working with me towards this big program of research. The idea for this program I'm going to talk to you about came about. I wrote an editorial with some colleagues a number of years ago now, back in 2019, about recognizing the psychosocial needs for carers, and some of the things that we sort of thought up back when we wrote this editorial were acknowledging that there's limited formal avenues for the identification and management of carer needs, and really starting to kind of put in place some thoughts around a stepped care approach, which is increasingly advocated for the routine psychosocial care of people with cancer, might be appropriate for use among carers as well. And I mean, this applies more broadly outside of cancer as well. And what stepped care is it's kind of an evidence-based stage system comprising kind of a hierarchy of interventions or services from the least to the most intensive, where it's matched to the person's level of need. So that's kind of, what the start of this whole thing was. I was then really fortunate back in 2023 to get a Cancer Institute New South Wales fellowship to actually test this, to test what does stepped care look like for carers. So I guess, one of the first questions that we asked was, how do we identify carers in need of support? And that's where screening tools come in. So in oncology, as is the case in most carer settings, there's no standard processes or tools to assess carers in need of support in a clinical kind of setting. There's lots of measures, as we've talked about today, across this wide array of measures, but not much clarity on which ones to use and when in a clinical setting. But we do know that there's a need for efficient and effective kind of routine screening for carers to be able to, identify those carers that have really high levels of need. I guess then the next question is, once we've done the screening, what happens next? So we did some qualitative work with healthcare professionals working with carers, and some of the quotes here, there's a high level of depression and anxiety amongst carers. That's clearly kind of recognised. But this one social worker said there's no way that the social workers and psychologists within a cancer centre would be able to support the carers. There's not enough of it. So I guess resourcing limitations. And another psychologist that I interviewed talked about, well, the problem is, where do we send you? Once we identify that there's carers who have high levels of need, where do we send you? Where can we find you kind of support that's matched to your needs? So to build on that, I think what we need is routine, purposeful assessment of carers' needs, but then also clear pathways for relevant, appropriate, and available support. So that's where we've developed what we call the carers can adapt pathway. Really based on that principle of stepped care, where we talk about there being in a world where there are kind of restrained, constrained resources. Where more intensive interventions are reserved for the carers who have the highest levels of need. And being able to kind of have clear targeted support that meets the needs of carers. So the carers can adapt stepped care pathway, goes across kind of 4 levels with carers, levels of psychosocial need increasing as you kind of get along that stepped care pathway, and having matched targeted supports for each of those different levels of distress. And the aim of my fellowship is really to, one, to develop this routine distress screening and mental health stepped care pathway for carers. 2, to kind of evaluate it and to see if it's feasible and appropriate. Can we actually do this? Can we do routine screening for distress and allocate people to a step and provide them with tailored support or targeted support? And then 3, to evaluate if this pathway and the associated interventions that sit within each of these steps are effective in helping to reduce carers' distress and unmet needs. So what the pathway consists of is carers will receive access, or they do receive access to a portal where they complete routine distress screening. And some of these are what we've talked about all of these today. So they do the distress thermometer, the GAD-7, the PHQ-9, and then what Rachel was just talking about, the supportive care needs survey 6-item screener. And then the portal, the back end of the portal kind of allocates a carer to a step in this pathway where we have 4 levels depending on the levels of the carer's need. So they log into this purpose-designed, secure portal and complete the screening. And the screening uses, as I said, the distress thermometer, as well as the GAD-7 and the PHQ-9 and the supportive care needs survey. So this is the kind of flow chart of someone working through this screening, the sort of routine screening. So you can see there, someone first starts with the distress thermometer. And for anyone in our study, and I hope eventually where this can get rolled out more broadly, so if someone completes the distress thermometer and they have a distress of less than 4, so 0, 1, 2, 3, then they're what we call in this distress negative, which then feeds into step 1, low levels of distress, and that's a universal care resources. For those carers who complete the distress thermometer, and it's at level 4 or higher, then that's where we kind of think about, okay, this was our screening. Now we need to delve into a bit more detail into, looking at what are this carer's levels of distress more specifically. So that's where we would use the PHQ-9, a measure of depression, and a GAD-7, which is the measure of anxiety. But sometimes someone can have high levels of distress on the distress thermometer. So they might have a 6 or a 7, but then they'll do the GAD-7 and the PHQ-9 and they come up in normal range. So that's where we would say that's step 2. And we would call that kind of non-psychological distress. It might be that someone's distressed, but it's not manifesting as kind of symptoms of depression or anxiety. It might be financial distress, relational distress, workplace distress. So that's where we've got step 2. Then we've got if someone does the distress thermometer and is 4 or more, again, distress positive, they complete the PHQ-9 and GAD-7. And if their levels come out in either of those 2 measures as in the mild to moderate range, they're allocated to step 3, which we have a targeted intervention for carers in that grouping. And then finally, if it's the GAD-7 and the PHQ-9 are in the high or very high range, that's what we would call then step 4, which is referral to more specialised psychological support services. So as you can see here, across these 4 steps, there's different resources which increase in their intensity as the levels of psychological distress increase in intensity. And the portal kind of provides access to people and recommends resources based on the step that they've been allocated to. So we're kind of situating this screening and stepped care pathway within a larger trial. So I guess I just wanted to demonstrate the types of measures that we're using in this study. So what I've showed you there was kind of in the middle, this screening and step allocation. But we've also got other measures which we're using really to kind of assess lots of different elements of this program. So we use the primary outcomes are, does all of this reduce symptoms of anxiety and depression? But we're also interested in seeing does this have an influence on unmet needs, on carer burden, and also carer fear of recurrence? So some of those measures that we've talked about today. We're also interested in looking at the process. So looking at outcomes of like satisfaction with the program and the process of doing this kind of a screening and stepped care allocation. And that'll be through a questionnaire and qualitative interviews. And then we also want to know, are there other things that are moderating or influencing people's outcomes, a carer's outcomes over these assessment periods? So we think that perceived social support, the level of social support that a person might have, as well as their support-seeking behaviours. So we're measuring them, of course, to see are they influencing outcomes. So at present, this trial's been going for the last 6 months. We've been recruiting, and so far we've recruited 115 carers of people with cancer to the study. And in terms of the numbers of people allocated to each of the levels here, so the steps across these 4 steps, I just put here the percentages of the numbers of people being allocated to each step. So you can see, obviously, the levels of distress are quite high, with the majority of people being either step 3 or step 4. So the plan here is to continue recruitment through 2025. We're going to map the unmet needs of carers to the different step allocations to see, are we addressing people's needs, and do they fit within the unmet needs in that 6-item screener? And then we're going to analyse the feasibility, acceptability, and effectiveness of the program. So I guess that's a bit of a watch this space of all of the different elements. But I guess what we wanted to do was be able to show you all, how all of these measures might fit into a clinical program or a screening program that might be able to be used in a service. So yeah, that's it from me. Thank you, everyone.
Thank you, Rebecca. I'd just like to say that as a carer and someone who's interacted with many carers, that I can echo that sentiment of there doesn't often seem like a clear pathway of where to go when there is distress. There are some generic pathways we're often offered, but those generic pathways aren't necessarily supportive or helpful. So I think this is really wonderful work, and this stepped care plan, I think could be really relevant for many carers, even beyond those who are caring for loved ones with cancer. We don't have much time, but I might ask one final question for all of our panelists today. And it's a generic question to an extent, and that is, what is the greatest challenge you face when doing research with the carer populations?
Someone else go first.
From my perspective, I think one of the biggest challenges is just the engagement. I think carers are so overly, burdened that it can be quite hard to recruit them into studies for obviously understandable reasons. But it does make it challenging for us to try to do our best to identify, what they need and to tailor supports for them because yeah, we need them to participate in the research to be able to answer those questions. So I think recruitment is a big challenge.
Yeah, I think that is very valid. I think more roles, similar to what I previously had in CKE, such as the care and residence, where it's reflecting the value of their time, can support in making that a bit more accessible. Yeah, anyone else want to comment?
Kira, have you got anything you want to add, or I can
No,
jump in?
I agree. I think just keeping the engagement as well throughout when you have longer
Yes.
projects. That's probably something that you can speak to a little bit more, Beck. Um,
You're right. I was going to say, I guess that it's not only getting carers into the study, which is always a challenge, and we're so cognizant of how much a carer has on their plate. You know, that research can be the last thing that anyone has time for. But also, I guess that for us, we would call it like attrition, which is when a carer is not able to continue in a study. That's another challenge. So we're doing, as I said, this stepped care pathway, um, and making sure that we can follow up carers over time, so that we can see, are things working, are things you know, and over time, are they having an influence? So I guess not only getting recruiting people, but being able to keep them in the study is always a challenge. Um, but a great privilege to be able to partner with carers whenever we can, to learn about what will help, and then at our end, I guess, advocate for evidence to then inform policy, which is kind of what our aim is all the time.
Thank you. Yeah, I can understand how maintaining that connection can sometimes be difficult. And I think from my own experience in participating, the best way to keep carers engaged is to allow them grace and flexibility. Um, Thank you so much. I think today's session has been extremely informative. I am very impressed with the work that you're all doing, and I think there is a lot of hope within the future of carer research, and to see how some of these measures can impact policy in particular. Um, so thank you for participating in today's session. It would be great if our participants could please complete the feedback poll that is about to appear on your screen. We also would like to acknowledge that the discussed topics may be challenging for some of us, and we would like to encourage you to take time to take care for yourself. Please also find some information about wellbeing resources on your screen shortly after this poll. And there are those wellbeing resources there for you now. So thank you all so much for attending today. There is more amazing content to come up throughout the whole incubator experience for the next couple of days. And thank you for those who participated in the chats. I'd like to acknowledge that your questions will be passed on to the presenters to be answered later. And thank you, Rebecca, Kira, and Rachel.